Okay, good day everybody. We are going to talk about headache. Headache is a common problem and has got a lot of causes. The differential diagnosis of headache is very wide. And to show you that it is a common problem, we will see or look at this problem in the UK. In the UK, 5.8 million people aged between 16 and 65 experience migraine, which is about 10%, approximately 10% of the population. 190,000 migraine attacks are experienced every day. 100,000 are absent from work or school every day, contributing to 25 million lost work or school days every year. Migraine is one of the 20 most common causes of years of life lived with disability. And the WHO recognizes the global burden of the disease survey rates the severe migraine along with quadriplegia, psychosis, and dementia in a group as the most disabling chronic disorders. And it has got a lot of causes. It can originate from the forehead, the temples, sinus, or in the back of the head, or in the scalp. Can be in the eyes, can be in the mouth, teeth, throat, neck problems, jaw problems, and the temporomandibular joint problems, as well as ear problems. For dentistry, we have these three causes: the teeth, the mouth, and the jaw problems. And we have three types of headache: tension headache, migraine headache, and cluster headache, which are termed, or they are classified as primary headaches. In tension headache, pain is like a band squeezing the head. In migraine, it takes one half of the head in the classic form, and in cluster headache the pain is around one eye. These are the primary headaches. The serious causes of headache: acute glaucoma, acute hypertension, acute lesions affecting the carotid vessels, brain tumors, giant cell arteritis, meningitis, subarachnoid hemorrhage, subdural or epidural hemorrhage. What are the indicators of the seriousness of headache? First, when the headache is abrupt or severe or bilateral headache. New headache after the age of 55. New persistent headache if it is preceded by head trauma. If it is or it follows a sore throat or a respiratory infection. If it is accompanied by mental confusion, fever, stiff neck, loss of consciousness or convulsions, rash, seizures, diplopia, weakness or numbness, pain in the eye or the ear, or dysarthria. Dysarthria is difficulty in speech. If it is disrupting the normal life, if the headache is repeated in children, if the headache is worsened by cough, straining, exertion, or movement. All these are indicators that this headache is serious and needs to be further investigated. It can be a serious cause, like the serious causes of headache we spoke about in the previous slide. The International Classification of Headache Disorders, it categorizes the headache into three categories. Part 1 are the primary headache disorders: the migraine, tension headache, and cluster headache. Part 2 are the secondary headache disorders, originating from problems in the skull bones, or in the neck, or in the eyes, ears, nose and sinuses, teeth, jaws, the TMJ disorders. And part 3, or the third category, are the cranial neuralgias and the central primary facial pains and other types of headaches. So the differential diagnosis of headache: we have part 1, the primary headaches, migraine, tension, and cluster headaches, and the secondary headache, and this can originate from a secondary cause, which can be intracranial, extracranial, systemic, or others. And we have the third category, the cranial neuralgias like trigeminal neuralgia, glossopharyngeal neuralgia, nervous intermediate, superior laryngeal, and occipital neuralgias. In secondary headache, the cause can be intracranial like tumors, hemorrhage, bleeding from an aneurysm, infection, TIA, transient ischemic attack or stroke, obstructive hydrocephalus, cerebral venous thrombosis. Or the cause can be extracranial like carotid or vertebral artery dissection, or local disorders like cause in the cranial skull bones, in the neck like cervical spine disorders, cervical spondylosis and these kind of things, eyes like glaucoma, ears, nose and sinuses, teeth and jaw problems, and TMJ disorders. Or there may be a systemic cause like hypertension, like altitude sickness, hypoxia, hypercapnia, polycythemia, systemic lupus erythematosus, temporal arthritis and other vasculitis, and many others. And we have the primary headache disorders, the migraine, tension headache, and cluster headache. So the differential diagnosis of headache is very huge. We have a lot of causes that can lead to headache. So the message is, differential diagnosis of headache is an enormous topic, and you need a strategy. First, think about the secondary causes, whether intracranial, extracranial, or systemic, and secondly, if the secondary causes are excluded, then think about the primary causes like the migraine, cluster headache, and tension headache. Tension headache. The typical patient can be any patient, particularly those who are emotionally tense, aggressive, frustrated, and anxious individuals. The frequency is chronic, often daily. The pain is mild to moderate in the form of pressure or tightness. Duration is around 30 minutes, and it can be repeated in 7 days of the week. I mean, it can occur daily, but the duration is usually around 30 minutes. The location on both sides of the head, and it can take the whole head and neck. And symptoms, there are no further symptoms, no light or sound sensitivity, no alarming symptoms, which we call aura. Aura are alarming symptoms. In migraine, the typical patient, it affects 14% of women and 7% of men, 2 to 3 times more common in women than in men. The frequency, it can occur like 1 to 2 attacks per year, or it can be as frequent as 2 to 3 attacks a week. The pain is moderate to severe. The character is pulsating or throbbing in nature. The duration can be from 4 hours up to 3 days continuous. The location usually one-sided, but the side can swap. An attack may come on the right side this time, and the next attack comes on the left side. We have triggers like foods, certain types of foods, spices, stress. And we have aura, which are alarming or warning symptoms like visual flashes of light, or sensory, certain numbness or feeling in any part of the body, or it can be motor, or there may be nausea and vomiting associated with this severe pain. And there is sensitivity to light, sound, and even smell. Cluster headache. The type of patient is middle-aged male smoker. Frequency, the clusters, it is called cluster headache because it usually the attacks of cluster headache occur at the same time each year or season, and then the rest of the year is free. So it comes in clusters. The pain is very severe, excruciating, penetrating, boring, continuous, but it is not throbbing. The duration is short, between 15 minutes to 3 hours, same time each day. For example, if the attack comes at 2 a.m., The next attack comes at the same time at 2 a.m. And there may be several episodes on a single day. The location always on the same side, and there are associated symptoms related to the eyes and the nose, like watery eyes, nasal stuffiness, running nose, red eye, swollen eyelids. The third category of headache are the neuropathic or craniofacial pain syndromes, and the most famous, the most common type of these syndromes are those affecting the trigeminal nerve, the trigeminal neuralgia. But these neuralgias can affect any nerve in the head and neck. For example, the glotopharyngeal nerve, the occipital nerve, the median nerve, but the most common is the trigeminal neuralgia. Trigeminal neuralgia is very common. It affects 50% of people above 50 years, and there are attacks, paroxysm, lasting only for a few seconds of severe stabbing pain, sort of electric pain in the trigeminal nerve distribution, especially the mandibular and maxillary divisions. There may be trigger areas that are stimulated by, for example, washing the face or shaving or even talking. Also, we have the post-herpetic neuralgia, where there is a burning pain, especially in the ophthalmic division of trigeminal nerve, which may be chronic. And finally, we have the atypical facial pain. This type is not diagnosed except after excluding all other causes of pain. Usually unilateral, more common in young females. It is severe, constant pain and not relieved by analgesics. So in the history, if we get or receive a patient with headache, we ask the following questions. How old were you when the headache started? How often do these attacks of headache come? Do they come in relationship to anything else? At what time do they come on? How do they start? Where is the pain, the location of the pain? How long does it last, the duration? How bad is it? How severe? Are there other symptoms with the headache? Does anything bring it on? What helps relieve the pain? Thank you very much.